Hi there, my name is Seth Sherman from Stanford University. It's a true honor to be invited to present at this virtual conference on return to sport following knee cartilage restoration. My disclosures can be found online. A special thanks to my friend Aaron Critch from the Mayo Clinic for some of the content relating to this talk. I'm a third-generation team physician. There you see my grandfather somewhere in the 1950s, safely returning this gentleman back to play. That's me on the sidelines, growing up with my grandfather by my side. And then actually my dad teaching me knee ligament evaluation on the high school football sidelines in Brooklyn. So it's kind of been a family business. And I was so thrilled to take my first job and become a team physician in the NCAA in the Southeastern Conference at the University of Missouri. And now more recently, over the last 2 years, as head team physician for Stanford football. So as I'm sure most of you in the audience do, we have to deal with issues in knee cartilage day in and day out, and they remain very challenging and, as we'll see, quite controversial. The problem is that cartilage lesions are prevalent, but they do not heal spontaneously. And the bigger problem is that there's no algorithm for the elite athlete. There's no perfect guidebook to go on. There's lack of evidence. There's surgeon bias and opinions. There's really no control groups. We're using return to sport as an endpoint, which is very different than the endpoint that we publish on in many other domains. There are different metrics for success than in other populations. Things that are multifactorial that influence it include age, eligibility status, contracting, et cetera. And so it makes it very, very difficult. The decision-making is also very difficult. We have to deal as the team physician with the coaches, with the organization, with the agents, with the parents, training staff, performance coaches. And so we're really making these challenging decisions without perfect evidence under pressure. And so how do we make sense of it all? I think when faced with some challenges like this, it's good to get help from your mentors. And so my dad's been a community surgeon for 30 years. And if you ask him about knee cartilage, he says, what, cartilage, it rarely needs to be treated. What am I, missing it all of these years? And there's some truth to that for sure. I trained at Rush University for fellowship under Brian Cole, one of my best mentors and friends. And he really has some of the highest cartilage volume in the world, but very, very strict indications. He believes in treating the here and now. We don't fully understand the natural history, and we can make people a lot worse. We want to start low on that reconstructive pyramid and perform bridging procedures and really be aware that we can do harm if we choose too aggressive too early. How about team physicians? Russ Warren, Scott Rodeo from the New York Giants from my residency, Pat Smith, head team physician from my early years at Mizzou. Again, the algorithm's different for elite athletes, and sometimes less is more. I think the take-home message here is to try to stay out of the operating room if at all possible. The last thing we ever want to do is to end an athlete's career with surgery. And so I think that's a very key point. However, on the flip side, the longer you wait, the worse it gets. Surgery greater than a year from an acute injury has a worse outcome. So there's certainly a balance here and a fine line that we have to go down. This can lead to athlete deconditioning. The cartilage defect size can progress. Subchondral bone changes can progress, malalignment. And so you can make a relatively straightforward problem worse. And so I think, we have to be thoughtful about being too conservative, too aggressive, and when to pull the trigger on these patients. Not all cartilage patients are the same. There's lesion-specific differences, joint and limb-specific differences, patient-specific factors. And so really no one-size-fits-all treatment for these athletes. Cartilage defects are extremely common. More than 60% are found in over 25,000 arthroscopies. However, the majority are asymptomatic, and so we must not overtreat. Cartilage lesions may be incidental. If you look at MRIs of asymptomatic NBA basketball players, up to 82% had abnormal findings. So if you want to find a reason to operate, do an MRI. However, that's only a very small window into the full clinical picture. Cartilage lesions may be incidental. We need to be careful not to barf or vomit. We don't want to apply brainless application of radiographic findings, and we don't want to be a victim of modern imaging technology. Two important principles. Cartilage surgery is not benign. We want to avoid iatrogenesis imperfecta, treating patients' symptoms and not the imaging study or the arthroscopic findings. Because we can do harm. We can turn incidental things into symptomatic and debilitating clinical problems with very long and expensive morbid treatment options. For example, this athlete had a scope microfracture of what very well might have been an incidental trochlea defect. He comes to us with debilitating pain, significant subchondral changes with cyst formation, and this is what it looked like open. And we needed to perform an osteochondral allograft just to get him back to daily life activities and to low impact recreation, not even return to his highest level of previous sports. We need to be very careful with our interventions. We need to think, why is there pain? Cartilage is aneural after all, so chondrosis on imaging does not equal pain. It's a diagnosis of exclusion. There are pain generators everywhere. They're in the joint, they're outside of the joint. We need to be systematic, thoughtful, and consider all of them. We need to treat patients on the basis of mechanically identifiable factors and their associated chondral defects, excluding ill-defined pain and those exceeding what Scott Dye would call their envelope of function. Patients like this, who come into your office with bilateral knee taping, elaborate patterns, and abnormal goals and expectations, we should send thoughtfully to our non-surgical colleagues. I always try non-surgical treatment if I can. Anti-inflammatories, biologic injections, sleeves, braces, core to floor rehabilitation. I want to gauge a patient's commitment, compliance, and response to treatment. I want to establish rapport before offering things like cartilage restoration. We must think of the joint as an organ, and we need to know before we go. Don't just look at the cartilage. Look at the alignment, stability, meniscus status, then look at the cartilage, then take that in consideration of the whole patient, and we'll start developing a nice regimen for treatment. For example, don't microfracture in Varus. I see this every single week. And unfortunately, these patients don't do well, and they require osteotomy, and some of them require concomitant cartilage restoration. This type of a situation could be avoided if we know before we go. And I get long leg mechanical access views on all of these athletes before I'm considering surgery, for sure. What's the ideal cartilage treatment? Well, we want to restore hyaline cartilage and or subchondral bone. We want it to be easy to perform and reproducible, low morbidity, early return to sport, high durability. And so guess what? This ideal solution, unfortunately, does not exist. Here's the landscape, I think, in the elite athlete. We can do things like chondroplasty. We can do microfractures. We can do OAT autograft. And that's pretty much the package for smaller defects. And then when we get to larger defects, we think about things like MACI and osteochondral allograft. And those are really my workhorse for larger defects for athletes. And we'll go through each of these in turn. Chondroplasty, it's easy to perform. It's safe. Fibrous tissue doesn't really regrow much. It's palliative for mechanical symptoms and loose bodies. Good for in-season athletes when you need something quickly, or for the aging athlete. And those are some of the principles and times where we might consider this. It's also good as the first stage of a comprehensive plan. Seen here, you can take a biopsy for a possible future MACI procedure. And so staging arthroscopy does have a role in knee joint preservation and cartilage restoration. What about microfracture? Certainly it's easy to perform. It has fibrocartilaginous fill, not hyaline cartilage. There are several concerns, and this really limits the application in my practice. Durability of the repair site with fibrocartilage, return to sport reliability, as I'll show you in a moment, longevity of those results, and it does burn bridges for other procedures, particularly cell-based cartilage repair. What about OAT autograft? You can see it here. It's technically more challenging, but it certainly can be done efficiently. It gives you hyaline cartilage. It heals like a fracture because it's your own patient's bone to their own bone. There's definitely concerns about donor site morbidity, especially if you're using more than one or two plugs, which I think limits its application, again, in my practice where we have some other options for larger defects. We've also started to see in America these fresh pre-cut osteochondral allografts. They're either 10 millimeters or 16 millimeters in size, and they may be a potential game changer over time, but we need much better evidence. We have to follow these patients carefully as a group. Here's a case example. You can see a 16 millimeter diameter defect of the medial femoral condyle. We can see a complex but repairable medial meniscus tear. And so in this athlete, we treat both. We do an extensive meniscus repair and a fresh osteochondral allograft in a single stage procedure. You can see how this looks during the surgery. It looks quite nice, and I was pleased with the early time zero look of things. However, as we learn in orthopedic surgery and certainly in sports medicine, there's no free lunch. And, I think what's going on beneath the surface, that bone needs to heal by creeping substitution, and that process takes a long, long time. And so, we can get burned by that. It can slow us down and limit our return to sport. And so we must be very careful before considering things like osteochondral allograft routinely in our elite athletic population. But in certain and salvage situations, it can be highly valuable to get people back to sport. Microfracture results. Not bad, 76% return for 4 to 5 seasons, 71% return greater than 2 seasons. That's reasonable. What about chondroplasty versus microfracture? 52 players. 67% return the following season, again, reasonable, but 4.4 times less likely if a microfracture was performed versus chondroplasty, an interesting finding in the NFL. OAT autographed 100 plus athletes with ACL and medial femoral condyle defect. OAT was superior to microfracture and chondroplasty. Another 17-year prospective multi-center study, 91% good, excellent with OAT. Donor site morbidity, only 5%. Again, a very reasonable thing in athletes. Another paper, 61 elite soccer athletes, greater than 9-year follow-up, 89% return to sport, about as good as it gets. And so 2 more papers to cite. OAT, again, superior to microfracture. When we look at Aaron Critch's article, you can see the return to sport. OAT autograft had the highest percentage, 93%, and the shortest time frame, 5 months. And compare that to microfracture, which was much less predictable and took much longer, about 9 months on average. And so you have this 22-year-old college football player has an ACL tear, a symptomatic medial femoral condyle cartilage defect, and they ask you, Doc, can I play in 6 months? I think based on our best evidence and with meticulous surgical technique, the answer can be an astounding yes, you can get those athletes with this specific problem back to sport, and that's great. What about for large defects? Osteochondral allograft and MACI are really my workhorse here. We published this recently in Cartilage. When stratifying commercially available cartilage procedures by FDA regulatory pathways, by far and away the best evidence was for MACI and osteochondral allograft. Everything else had quite poor evidence. And so we need to be thoughtful with all the new products out on the market. They sound good. Ask for the animal data, ask for the preclinical, clinical studies, see if they match up to MACI and osteochondral allograft, which will be near impossible given the substantial amount of evidence over several decades for both of those interventions. When you think about MACI versus osteochondral allograft, it's really seed versus sod. Cell-based repair, you can see here, you have the defect, you apply cells on a matrix, and then they remodel and grow cartilage over time. It's typically hyaline-like cartilage, but it can get quite firm and durable. Here's a article, 41 pro soccer players, greater than 7-year follow-up. ACI was better than microfracture, 86% return to sport. ACI was durable, microfracture deteriorated over time. Here you can see osteochondral allograft. And so you can see a beautiful transplant at time 0. Looking at this study, 11 players, 80% return to sport at 14 months. That's pretty good in the NBA. Here we have 43 athletes, again, 80% full return, risk factors for not returning, age greater than 25, and symptoms greater than 1 year. Return to sport, you can see osteochondral allograft, 88%, average about 9 months for osteochondral allograft versus 11 months for ACI, but both were relatively equivalent regarding return to sport. And so in conclusion, cartilage defects are common, but most are asymptomatic. We want to treat elite athletes without surgery whenever possible, especially with multifocal disease. We don't have excellent solutions for that. Acute injuries do better when surgically treated within 1 year. If symptoms persist, pain, effusion, mechanical symptoms. So if you've tried everything and these patients are still suffering, then we should treat them within a year using the algorithm I've described. Microfracture results degrade over time and may burn bridges. OAT autograft has the best evidence for small defects and is our preferred treatment strategy for those patients. Consider osteochondral allograft and MACI for larger defects, especially with longer career expectancy. The ideal cartilage procedure is not yet proven, and there's limited evidence to guide our current choices. So hopefully this was informative, and I wish you a wonderful meeting. I look forward to getting across the pond and seeing all my friends in the UK in the near future, and have a wonderful time. Take care. Bye.